Good morning, Rajesh. Good
Good
morning,
morning, sir.
Kapoor
Good
sir.
morning.
Good morning,
Good morning,
Anand and
Rajendra sir.
everybody else. Good morning, Anand.
Rajiv, you are joined.
Yes, sir. Hassan, I am just sharing my screen, sir.
You can share a screen.
Sir, is it visible, sir?
Yeah,
Okay.
go to
Shall I
full
start, sir?
screen. Go to full screen.
Yes, sir.
Yeah, start.
Shall I start the presentation, sir?
Do we have to wait for Kapoor sir, Anand?
No, sir, Kapoor sir probably somewhere busy, sir. He is busy. So you can start
Okay.
in 9 o'clock, 1 minute. So it's sharp 9 o'clock. Rajiv, you can start in sharp 9 o'clock, 1 minute. So other
Okay,
people
okay,
can join.
okay, sir.
You can start, Rajiv.
Yes. Good morning, everyone. The case I'm presenting today is of a 75-year-old male. He's a shopkeeper, stationery and book depot he runs, and he's coming from Faizabad in Uttar Pradesh. And he came with the complaints of yellowish discoloration of sclera and urine for 1.5 months, and pruritus for 1 month, and fever 20 days back. He noticed yellowish discoloration. Previous to that, he was apparently asymptomatic around 1.5 months back. Yellowish discoloration of sclera and urine, which was insidious in onset, gradually progressive, without any waxing and waning symptoms. No associated pain abdomen, and he did not have any pale colored stools, and it was not preceded by any prodromal symptoms like malaise, headache, nausea, or vomiting. He also gives the history of associated pruritus for last 1 month, which was gradually progressive, started in hands and progressed to the entire body. Now he is having generalized pruritus, which is also affecting his day-to-day activity, and he is having disturbed sleep because of the severe pruritus. He gives history of fever 20 days back he had for 3 to 4 days, which was a high grade intermittent associated with chills and rigors. He used to have 2 to 3 episodes of fever per day, which lasted for around 1 to 2 hours. For which he had consulted in a private hospital outside where he was given IV and oral medication, and after that fever got subsided after fourth or fifth day. Exact documents are not available which medications he was put on. And he also gives a history of loss of appetite. Initially he used to take 3 to 4 meals per day, and around 3 to 4 rotis with a bowl of rice. Now he is taking only one and a half roti, that too twice daily, and after that he's not feeling any appetite. He also gives history of weight loss, which is not quantifiable. He does not have any accurate measurements. Still, he complains of losing of weight. He noticed in terms of loosening of clothes and general. There is no history of vomiting, no history of abdominal distension, no history of hematemesis or melena, no history of cough, hemoptysis, back pain or bony pain. There is no history of recent travel to any endemic places. Then he does not have any known medical comorbidities. There is no past surgical history. He's a vegetarian by diet. Appetite is reduced since the last 1.5 months since he's having these symptoms. He's non-smoker, non-alcoholic. He has disturbed sleep because of pruritus, and bowel habits are otherwise normal. In family history, there was nothing contributory. None of the family relatives were affected by similar disease, or there was no history of malignancy, or anyone died or got operated for due to any malignancies. Shall I summarize the case, sir?
Yes, please.
Yes, sir. 75-year-old male with no known comorbidities presented with painless progressive jaundice for 1.5 months with intractable pruritus and symptoms suggestive of cholangitis with history of loss of weight and loss of appetite.
Yeah. Let us go back to the history. Go back to the first page.
Yes, sir.
Yeah.
Yes, sir.
No, go to the demographics.
Sir?
Go to the demographics.
Yes, sir.
Yeah. He is 75 years old. At 75 years old, what are the causes for jaundice?
75-year-old. There can be medical causes, and in surgical causes, it can be benign or malignant.
Medical
Among
causes
medical,
are more common or surgical causes are more common at that age?
sir, jaundice at any age, more common will be medical viral hepatitis.
Okay, but you
And
don't expect
actually,
him to be sexually active or receive an injection or anything. So he is more
yes, sir.
likely to develop a surgical cause.
Surgical. Yes, sir. Among surgical, both the benign and malignant are there. Still, benign are more common at any age of at any age. But one of the factor towards malignancy, if we see, age can be one of the factor.
Okay, go on. What about
Uh,
Faizabad? How does Faizabad work into the diagnosis of obstructive jaundice?
Sir, Faizabad is in Uttar Pradesh. It is in the Gangetic Belt, where gallbladder carcinoma or even HPV related malignancies are more common. Sir, it's an endemic place for gallbladder cancer.
It's also an endemic place for hepatitis B. So you can
Yes, sir.
also get hepatitis B cirrhosis and you can get hepatocellular carcinoma.
Yes, sir.
It's also an endemic area for cholangiocarcinoma.
That is sir. Okay.
Yeah.
Okay, sir.
So go on.
Uh, shall I
So
go to different?
now
Yes.
with these 3 points in mind, I say this is CBD stone. What are your factors for and against CBD stone?
Sir, for CBD stone, this one features of cholangitis, pruritus, and fairly 1 month history, fairly in less duration, can be one of the. And against, sir, there is no history of
No, what about
biliary
clay
colic.
colored stools? He doesn't have clay colored stools.
Yes, sir. Not,
That's
yeah,
also a point in
no,
favor of a
point
CBD
in
stone or a
favor.
partial obstruction.
Yes, sir. And also against points are there is no history of biliary colic, sir.
Okay.
It can still be a first episode.
You did not
Yeah.
mention past history of gallstone disease or
Yes, sir.
symptoms of gallstone disease. You have to
Yes, sir.
mention that.
That's what. Uh, even this can happen at. It can be a first episode, but if there was a history of past similar episode, it would have been more favoring choledocholitis.
What other causes could come to mind?
Sir,
What about autoimmune cholangitis?
autoimmune cholangitis, sir.
Yeah, IgE disease.
So the age maybe not very common in. Usually, presentation will be in third to fourth decade of life, sir.
Usually in the 50s and 60s,
Okay, sir.
not in the 70s and 80s.
Yes, sir.
Also, there will be a slightly longer history. There will
Yes,
be
sir.
other history of
Duration of.
autoimmune disease. He will have vitiligo, he will have thyroid disease, he will have other illnesses.
Yes, sir.
He may have pancreatic pain because of associated IgE
Pancreatic.
pancreatitis.
Pancreatitis.
Okay, go on. Go to the next page. What is the progression of pruritus? Where does pruritus first appear?
Sir, usually appears more in periphery because large number of density of nerve endings
It
are
is
there in
more
periphery.
common on the
So,
trunk and at night.
yes, sir. That is
Then it
also
spreads to the periphery.
okay, sir.
Hmm. Go on. What are all the areas where you look for jaundice?
Sir, sclera is where it appears first, then floor of the mouth, and then
Sclera is not first.
floor
Soft
of
palate
the
is first.
okay, soft palate, sclera, floor of the mouth, and then uh, chest, abdomen, and then in the palm and soles, it comes in the last.
Yeah. And if it's in the palms and soles, it is severe jaundice.
Severe, yes, more than 18.
Why do you get yellowish discoloration in the sclera? Why
So
sclera?
because so because of white background and vascularity. It is more obvious in.
It is because it contains elastin fibers, and elastin fibers get stained with bile salts and bile pigments.
Okay, sir.
That's why you get yellowish discoloration of the skin. It's the
Yes,
elastin of the skin that gets colored by
bile
jaundice.
pigments. Yes,
Okay, go on. Now let us
sorry.
come to the history of cholangitis.
Yes, sir.
How easy is it to control cholangitis without drainage of this system?
Sir, in case
When
of
will you
partially
drain the
obstructed.
system? When will you drain the system? When will you not drain the system?
Uh, Sir, coming to the first question, sir, in case of partial obstruction, if patient has cholangitis, it is fairly controllable with IV antibiotics. We go for drainage in case of uncontrolled cholangitis, where we have given broad spectrum antibiotic for around 24 to 48 hours, and still patient is persistently having fever, or there is no reduction in inflammatory parameters on blood
It is
investigation.
important to
Then
realize that any patient with obstructive cause of jaundice
yes, sir.
should be drained.
Yes.
They should be drained. You can start antibiotics, presuming they will work, but you have to drain the system as quickly as possible.
Yes, sir.
What are the methods of draining the biliary system?
So best method would be internal drainage by ERC stenting, and other than that, external with PCD insertion, which can be just a external drainage, or internal external, where we can pass the PCD across the obstruction, or we can put a stent.
When do you prefer a nasobiliary drain rather than a stent?
Nasobiliary drainage, when we might be requiring repeated cholangiogram to look for, in case of suspected obstruction post this thing, sir, post clearance of the
More
CBD.
importantly, it is to give irrigation of the biliary tree. So if the
Yes,
bile that is
apparently.
draining is turbid, there is a lot of debris,
Yes,
there
sir.
is a lot of stone debris, there is a lot of sludge. Then you prefer to put a nasobiliary
Nasobiliary
tube
drainage. Yes,
so that you can irrigate the system and you can drain out the system. And
yes,
also, the disadvantage is it is uncomfortable, but other than being uncomfortable, it is advantage.
yes,
Now, you said internal drainage is preferred. Why is
yes, sir.
internal drainage of jaundice preferred? How does it help?
So it is more physiological route, and bile gets mixed with the food, and it helps in his digestion also.
Okay, what else?
Then
What happens to
enterohepatic.
the enterocytes?
So enterohepatic circulation is maintained, and hello, sir. Enterocytes.
Hmm.
Uh,
The gap junctions will be tight.
okay,
If there is no bile in the system and there is an infection, you get loosening of the gaps of the enterocytes, gap
okay, sir.
junctions of the enterocytes. And this results in permeability and it starts the engine of multiple system organ failure. The gut engine
Okay,
of
sir.
multiple system organ failure starts. So you prefer
Yes,
an internal drainage. Okay.
yes.
How many drains will you put? What caliber drains will you put? Will you put metallic tube? Will you put short metallic tube? Will you put plastic tube? If so, plastic tube, what caliber and how many tubes?
So number of tubes depends upon the level of obstruction, sir. In case if the level of obstruction is below the hilum, and all the three systems are communicating, that is right, anterior, posterior, and left, we can put one drain in any of the systems. In case if it is involving the hilum, and there is a ductal separation of all three of these systems, and if it is involving secondary radicals and beyond, we may need choose to put multiple drains. Need not be necessarily, in case it will be depending upon what surgery or what we are planning later. We'll be first draining the lobe, which is more healthier than the other ones, And regarding metallic stent, sir, it is usually
It's
used
to
in
say
case.
not healthier, but
Yes,
the part that will be left behind should be drained.
yes, sir.
But in
But
presence
we
of
are choosing.
cholangitis, all systems should be drained. In the presence of
Yes,
cholangitis, you cannot drain only one system because the other system may be
yes, sir.
infected
If
and
it is
sepsis
not
will continue.
communicating all
In
three systems.
cholangitis, all systems should be drained. It's
Yes,
very,
sir.
very important. That's why
Okay, sir.
Nimura's group puts multiple tubes of PTBD into the biliary tree to drain all the systems successfully.
Yes.
What are the indications for PTBD?
PTBD, sir.
Yeah.
Hilar block where we are not able to do ERC stenting, where guide wire cannot be passed, or hilar or above the hilar block leading to primary or secondary confluence where ductal separation is there with the patient in all these in a patient having cholangitis, sir, uncontrolled
Okay.
cholangitis.
Okay.
And
Now,
some groups prefer putting routine drainage if bilirubin is more than 20 or 30.
15. 15 is,
Yes, sir. 15.
yeah. And okay. So he had 2 to 3 episodes of bidet. They lasted for 1 to 2 hours and they subsided after IV and oral medication. Once you
Yes.
do this, what's the first investigation that you would like?
Sir, actually, radiological investigation, I would go for at least ultrasonography at that point and
Why
MRCP, sir.
ultrasound first?
Sir, for all pathologies of liver and biliary system, ultrasonography can still fairly diagnose most of the cases.
Okay.
If not accurately, at least the level of obstruction can be easily made out with ultrasound with a good experienced radiologist.
Okay. Would you prefer
And
blood investigations first or both together simultaneously?
so I would prefer both, sir, to look for the severity of cholangitis and also the level of obstruction.
Okay. So tell us the investigations now.
Sir,
What is
shall I
your
directly?
give me a differential
Yes,
diagnosis at this point.
yes, sir. Considering his history that I just summarized, I would consider differential diagnosis of periampullary carcinoma, carcinoma gallbladder, carcinoma head of pancreas, and cholangiocarcinoma in this order. However,
Except weight loss, there's no other
yes, sir.
feature against benign disease.
Yes,
You
sir. That's
should
what.
include
However,
benign disease.
yes, sir. However, with this history information, we cannot rule out benign causes like maybe Mirizi syndrome or choledochal cyst at this point, sir.
Choledochal cyst, I would put it out. She's 75 years old. Bit
Yeah,
unusual.
less likely.
Very,
Yes, sir.
very unusual. Very, very
Yes.
unusual. More likely is CBD stone. More likely is uh, malignancy. Okay, go on.
Yes.
Give for
Coming to
each
general.
of these give for each of these diagnoses defending and negative factors. Why do you say periampullary carcinoma?
Periampullary carcinoma, sir, classical painless progressive jaundice is one of the factor towards the periampullary carcinoma. And one point against that would be cholangitis. Although it can happen both in malignant and benign diseases, it is more common in benign. Then, sir, carcinoma gallbladder, one factor that favors is his location, where he comes from, his site of residence, that is Gangetic Belt, and his age also, sir, and it is more common in those areas. One of the factors against is no pain abdomen in him. That can be a thing against, sir. And CA head of pancreas also again will have some amount of dull aching continuous pain. And factor against that is a factor against CA head of pancreas, and factors favoring CA head of pancreas would be, sir, again progressive jaundice.
Elderly man, that also is a factor in favor.
Yes, sir. Yes, sir. Then cholangiocarcinoma can also be there in him, sir, with painless progressive jaundice, but cholangitis is against cholangiocarcinoma again.
I don't agree because cholangiocarcinoma, usually there is a lot of necrotic tissue with bulky tumors, especially
Yes, sir.
papillary tumors. They lead to multiple levels of obstruction, and the necrotic tissue,
Can cause cholangitis. Yes.
you can get malignant, you can get cholangitis.
Yes.
Yeah, go on.
Yes. Coming to general physical examination is moderately built and are conscious oriented. His BMI is 23 kg per meter square with ECOG of 0. Vitals are fairly normal, sir, with the pulse of 90 beats per minute, blood pressure of 138/78, and he's afebrile at the time of examination, sir. Icterus is present. Scratch marks are noted over the trunk and both upper and lower limbs. There is no pallor, lymphadenopathy like generalized lymphadenopathy or left supraclavicular lymph nodes and pedal edema, sir. No other peripheral signs of chronic liver disease, sir. Then coming to
What are
his
the
abdominal,
peripheral signs of chronic liver disease?
sir, jaundice, malar rash, then
Jaundice is there.
yes, sir, malar rash. Then in case of alcoholic, parotid
What
enlargement
are
is
the
more.
ones that are true of alcohol and those that are true of non-alcohol?
Sir, parotid enlargement and maybe Dupuytren's contracture is more common in alcohol, sir.
Okay.
Then in non-alcohol, spider nevi, then other features of uh, flapping tremors, uh, common in
What
both
about
alcohol and
gynecomastia?
gynecomastia, yes, sir. One of the
What else?
gynecomastia. Sir,
What
loss of
about testicular
facial hair,
atrophy?
body hair, testicular atrophy, pedal edema, abdominal enlargement, caput medusae.
Testicular atrophy is more common in alcoholic or non-alcoholic?
Which one, sir?
Testicular atrophy.
Testicular atrophy, sir, I don't have actual knowledge on
It's
that, sir, but no,
alcoholic. It's
yes, sir.
alcoholic. And
Okay,
the reason is there is a direct toxic effect of alcohol and there's an effect of estrogen being produced by the liver,
okay,
not being metabolized by the liver. So estrogen and direct toxic effect of alcohol both result in testicular atrophy.
okay, sir.
Yeah, go on. So you said external genitalia and spine are normal. So basically you can rule out chronic liver disease.
Yes, sir.
Visible veins are also in favor of chronic liver disease.
Chronic liver disease, sir. Yes, sir.
Spider telangiectasia are also in favor of chronic liver disease.
Mhm. Yes, sir.
Where will you look for spider telangiectasia and what is the level of abnormal spider telangiectasia?
Sir, usually over the chest, spider telangiectasia, usually seen
You
over
should
the
look
chest, sir.
in the distribution of the superior vena cava. Face,
Superior,
upper
yes,
limbs, chest, front and back, up to the nipples.
nipple, yes.
More than how many is significant in males? More than how many is significant in females?
So more than three are significant, sir. I don't know in male and
In
female
females, it's
separately.
more than five.
Right. Okay, sir.
And what is the difference between dark-skinned individuals and light-skinned individuals when you are examining for spiral telangiectasia?
Some more visible, more appreciable in case of bright skin individuals
You
than in
get a
dark skin.
spider appearance in fair-skinned individuals.
Yes.
In black-skinned or
Well,
dark-skinned individuals, you just get a blanchable dot.
normal black spot. Yes.
Yeah. Okay, go on.
Coming to palpation, sir, abdomen was soft, non-tender. Gallbladder is palpable, 8 centimeter lateral to midline, just below the costal margin. It is globular, smooth surface, non-tender, well-defined margins, all except the superior margin. It was firm in consistency, moves with respiration, and side-to-side mobility is present. There is no other palpable mass, no hepatosplenomegaly, hernial
Was
orifices,
it
and external
tension
genitalia.
cystic or firm?
So firm, sir, not tensile cystic. At the time of examination, it was firm.
So you're thinking it is tumor rather than a distended gallbladder.
Sir, since side-to-side mobility was present, it is unlikely. But however, we cannot rule out carcinoma neck of the gallbladder, in which
Not
side-to-side mobility
carcinoma
can.
neck of the gallbladder is also a distension.
Yes, sir.
You said
But
the gallbladder mass is firm. So that
yes, sir.
means a bulky type of gallbladder carcinoma or a fundal type or body type of gallbladder carcinoma you are thinking of. That's what you are making the sense in the
Like,
way you are
no, sir.
presenting it.
Firm in consistency because of like I filled because it was filled with bile, sir, not in the sense of mass.
What is in favor of that argument? You are saying that, but I say no. How will you contradict me?
So mobility of the gallbladder will be usually
Not
restricted in case
mobility, but it is smooth and globular.
smooth globular and well-defined
But the
margins. Yes, sir.
gallbladder malignancy, it will be irregular and it will be bulky and it will be firm and it will be tender.
Okay, sir.
Yeah, go on.
Then on percussion, liver dullness starts from fifth intercostal space and liver span was 12 centimeter.
So
Dull
it's
note
normal.
heard over, yes, sir. Abdomen, there was no evidence of free fluids, sir. Auscultation also, normal bowels also there. Rectal examination, perineal skill is normal, no sinus, fistula or hemorrhoids. Sphincter tone is normal. Finger glove stained yellow stools, no evidence of blood or melena. There were no palpable nodules in the uh, walls of the. Yes, sir.
Can you rule
Then
out
coming,
cholangiocarcinoma?
can we rule out cholangiocarcinoma, sir?
Hmm.
Sir, hilar cholangiocarcinoma we can rule out because gallbladder was enlarged. However, mid CBD cholangiocarcinoma or distal cholangiocarcinoma may not be ruled out at this.
Anything obstructing the cystic duct, you cannot rule out.
Yes, sir.
Whatever the insertion of the cystic duct, depending on the
Yes.
insertion of the cystic duct, the location of the tumor may be different. If the
Yes,
cystic
sir.
duct origin is involved, then it can cause distension because of a mucosid.
Yeah.
But
Yes, sir.
otherwise, in a hilar cholangiocarcinoma, the gallbladder is usually collapsed.
Yes.
Okay, go on.
Coming to systemic examination, respiratory system and CVS, CNS were fairly unremarkable, sir.
Okay, go on.
To summarize at this point, 75-year-old male with no known comorbidities presented with painless progressive jaundice of 1.5 months duration, intractable pruritus, and symptoms suggestive of cholangitis, and history of loss of weight and loss of appetite. He is icteric with scratch marks and distended gallbladder on examination. No other palpable mass or hepatosplenomegaly. Rest of the examination was unremarkable.
You didn't give his ECOG stage, you didn't give his BMI, you didn't
So
give his
it was there.
nutritional status.
So it was there
BMI
initially.
you gave. Okay, ECOG is zero.
ECG also.
Yeah, what
Yes.
about his nutritional status? How do you measure nutritional status in patients with malignancy?
So mid-arm circumference
What
and
is triceps fold thickness and abdominal wall fold thickness? What is the normal value?
so normal value, I don't remember, sir. It used
For
measured with
triceps
caliper.
fold thickness, it is 1 centimeter and it is one
Yes.
inch for abdominal fold thickness. Anything
Okay, sir.
less than that, it means the patient has a low subcutaneous fat level.
Fat level.
Might not mean he has lost it. He could have it because he is the bodybuilder, but he has a low
Yes.
fat percentage. Mid-arm
Yes.
circumstance gives a concept about the muscular mass as well as the fat,
Visual
subcutaneous
fat.
fat.
Yes, sir.
And overall build also you have to keep an eye. Is he looking muscular, emaciated? Is he looking thin? BMI of 23 is normal, nearly normal BMI.
No.
25
Yes.
I would say is normal. 23
Yes.
is normal BMI. So I
Yes.
assume you mean to say that his weight loss is not terrible. It is significant, but it is not terrible.
Not. Yes.
Has he had to tighten his belt to fasten his pants? Or has to try a cord to tie his pants?
No, sir. He is just having loosening of clothes, but however, not that
So it is
significant.
less. It has just
Less.
started. The weight loss has just
Yes.
started. Okay.
Yes.
Go on. Go on.
Differential diagnosis, again, I would keep peremptory carcinoma, carcinoma gallbladder, carcinoma head of pancreas, and cholangiocarcinoma, but not the hilar cholangiocarcinoma,
I
mid
would put
CBD or distal
carcinoma
CBD.
head of the pancreas ahead of carcinoma of the gallbladder because the gallbladder is palpable and it's dense and cystic.
Okay, sir.
In carcinoma of the gallbladder, except for neck gallbladder tumors, you wouldn't get a palpable
Less.
gallbladder.
Yes.
Mostly it is contracted and infiltrating into the liver bed, and there'll be it will be continuous with liver dullness, and you will feel an irregularity in the liver.
Yes.
Okay. Cholangiocarcinoma, I would put it very low in the priority as of now.
Yes.
Okay. Let us go.
I'll go with the investigation, sir. His blood investigations were suggestive of obstructive jaundice with total bilirubin of 7.7 and direct bilirubin of 6.7, which were done outside, and SGOT, SGPT were elevated around 1.5 times, and alkaline phosphatase was raised. And after admission, also
What
they
is
were
the
progressively
significance of a raised SGOT, SGPT?
SGOT, SGPT, sir. The backflow is
Yeah.
affecting the hepatocytes
No,
pressure.
that is alkaline phosphatase. Here it
Cholangitis,
is
sir, in
because
this
of
patient.
sudden rise in pressure, because of
Pressure,
cholangitis,
cholangitis.
sudden rise
Yes,
in pressure leads to a rise in SGOT, SGPT. Okay.
yes, sir.
Alkaline
And
phosphatase is
then,
raised, and it is serially
and
rising.
yes, sir. And albumin 3.8 fairly suggests his still maintained nutritional status.
Okay. Could he be dehydrated?
Um, so
You didn't
creatinine,
mention dehydration in the picture.
sir. Hello,
You
sir.
didn't mention dehydration. Well hydrated, you didn't mention.
Yes, sir. Tongue
So,
was, yes,
in
sir.
the
I had not
absence of
mentioned.
that,
Tongue was moist.
high albumin can be there because of dehydration.
Yes, sir.
And with bile salts and bile pigments, is there diuresis or is there reduction in urine output?
Bile salts and bile pigments, so reduction.
Yeah,
Bile
reduction in
salts
urine
was,
output
yes, sir.
because they injure the kidney.
Yes, sir.
Okay, go on.
Then he has a ultrasonography report, sir, which shows the peripheral as well as central intrahepatic biliary radical dilatation with patent confluence. CBD is also dilated around almost 2 centimeter in size. There is evidence of approximately around 2 into 2 centimeter sized heteroechoic lesion involving the distal most part of the CBD and ampulla. MPD was also dilated approximately 5 millimeters, sir.
What is
There
the
were few
sign called?
double duct signs, sir.
Okay. How
Then,
do you differentiate between double duct sign in carcinoma of the pancreas and periampullary carcinoma?
sir, in carcinoma head of pancreas, double duct sign will be there, but both of them will not be meeting, sir. There will be ductal
Okay.
separation. And initially, the double ductal sign was uh, elaborated or described for carcinoma head of pancreas, but it is seen also in ampullary carcinoma. But here, both CBD and pancreatic duct will be meetings. Confluence will be
Okay.
there.
Okay. Go on.
Yes, sir. There was no evidence of any free fluid or obvious lymphadenopathy, sir, on USG. Uh, USS. I'll go to the next investigation.
What lymph nodes did you look for on USG in this case?
So lymph nodes along periportal, portocaval lymph nodes and pancreatic, retropancreatic group of lymph nodes.
Okay. Retropancreatic and periportal lymph nodes and celiac group of lymph nodes last.
Ceiling. Yes.
Yeah. Okay. What else?
Uh, Lymph nodes, sir?
No, no. What else? Go on.
Yes, sir. Patient actually was referred to us from outside, sir. They patient already had USG and they had also got
Was
a
there any
contrast
evidence of
enhanced
chronic pancreatitis?
on USG. No, sir.
Okay.
No ductal calcification or parenchymal calcification. So patient was referred to us with contrast enhanced MRI, sir,
Okay.
which was showing a
Is this
hyperretinal lesion.
preferable or not preferable?
Sir,
Is MRI preferable or CT preferable? What are the arguments for and against MRI and CT?
So theoretically, MRI has more sensitivity and specificity compared to CT. It has a better soft tissue characterization. However, for soft tissue characterization for primary lesion or metastasis and also. However, most of the surgeons do prefer triple phase CT where we can see the vascular pattern better, and also it is more
MRI
readily.
is good for
Yes,
liver metastasis,
liver mets.
sub-centimeter liver metastasis,
Yes, sir.
and lymph nodes. While vessel invasion is better made out in
Triple
angiogram,
phase.
CT angiogram.
Yes,
And CT is more interpretable by surgeons because they are more familiar with the anatomy.
yes, sir.
But the MRI margin of the pancreatic tumor is better than compared to the CT margin.
Yes, sir.
Do you want to do an endoscopic ultrasound
In
or
case
a
of a
side
suspected,
endoscopy?
yes, sir, side wing scopy or endoscopic ultrasound both can help. Side wing scopy was done in this patient, sir, after MRI.
Okay, what was it showing?
Side wing scopy showed a second, bulky papilla with overlying altered mucosa, and a biopsy was taken from side wing endoscopy.
Okay, was it positive?
Yes, sir. It was positive for adenomatous polyp with high grade dysplasia.
So that means there is a possibility of an in situ carcinoma being present.
Yes, sir.
Okay, let us go back to the
This was.
MRI images and discuss the MRI images.
Yes, sir. MRI contrast enhanced MR image of abdomen cell, triple phase contrast enhanced image was taken. The first image I'm showing is of T2 weighted image with contrast, and the cut I'm showing is of the distal CBD and ampullary region, where there
Okay,
is a hyperetenating lesion at the ampulla cell.
okay.
This is the lesion that they are describing, and
Too circular.
I'll be showing you. Sir?
It is too smooth and circular. That is
Yes,
because
sir.
the mucosa is intact.
Yes, sir. Mucosa
Yeah.
was intact at that point. And I'll be showing the video, sir, later where it shows
What about
dilated
the portal vein?
CBD. Portal vein is normal, sir, without any. Portal vein is not abutting, far from the lesion, and without any echoes inside the portal vein, sir, without any intensity
Okay.
vein, sir.
IVC?
IVC is also normal, sir, without any abutment or.
Okay.
This is the video, sir, T2 weighted image, which is showing grossly dilated biliary radicals and grossly dilated gallbladder,
Is
both
there anything in
MPD
the
and
liver?
there are simple
Go
cysts
back,
are there in the liver, sir. Yes,
go back, go back, go back. Go slow.
one second, sir.
There appears to be some fatty liver.
Okay, sir.
Okay, go
Back to
on.
you.
And some focal fat replacement is there.
Sorry. This is grossly dilated CBD and gallbladder, sir.
Okay.
Then uh, here the pancreatic duct can also be seen dilated. Both of them are meeting and having confluence, and just after that, there is this lesions.
Okay. And the CBD is disappearing?
CBD is disappearing just above that lesion, sir.
Okay.
This is the same scan in T1 weighted image, sir, with
Okay.
arterial case, where all the arteries and major vessels are seen far away from the
Any
lesion, sir.
abnormal arteries?
No, sir. CHA is forming right and left hepatic artery proper, sir. And then gastroduodenal artery is also far away.
Okay.
There is no replaced right hepatic artery or left hepatic artery. No X-rays.
Okay.
Yes, sir. Side wing endoscopy, sir, and its report was adenomatous polyp of the high grade. And later, sir,
Why
patient,
was this patient not stented? At the time of side viewing scopy, why was an ERCP stenting not done?
sir, his fever was 20 days back and it was subsided after 5 days. However,
But
sir,
his but his
I'm
SGPT, SGOT was raised, his counts were raised.
Yes, sir. That's what, sir. I am just coming to that part, sir. On the date of admission, he did not have any features of cholangitis, and his SGP OTPT were raised. However, TLC was normal, sir. But during his hospital stay, he developed 2 episodes of fever of 102 Fahrenheit. The blood report showed increased TLC and increase in SGOTPT and this thing, sir. That's why patient was planned and ERC stenting was done, sir.
Okay. Would you prefer a short metallic stent or a plastic stent in a periampullary carcinoma? Nowadays, you have
Sh-
short metallic stents so
yes, sir.
that you
That
can
will
do
be
a
more.
Whipple.
Yes, that will be more preferable. It avoids a blockage of pancreatic duct also.
Yeah, and also it has
Completely.
got a better drainage of the biliary system.
Yes, sir.
Yeah. So I would prefer to do that. But
Short
ten
patients.
French 7 centimeter straight plastic stent, I would put 2 to 3 stents, not one stent. There's a very dilated CBD. I would put two to
Okay, sir.
three stents. Basically, because if you put one stent, stent migration is very common
Okay, sir.
because it's such a capacious bile duct and papilla that if you
Yes, sir.
just put one stent, it will migrate. Okay.
Yes.
So now that we know what it is, what is your plan of action?
So plan of action.
Is there an increased size of the aorta cable node
No,
on the
sir.
MRI?
No, sir.
No. So what would you like to do? Let us
So
assume
since
you believe in a laparoscopic Whipples. Is this a patient suitable for laparoscopic Whipples?
yes, sir. Patient is suitable for laparoscopy.
Okay. Tell me how you plan for that.
Sir, as patient had recent history of cholangitis and we have done stenting, ideally we'll wait for the cholangitis to settle down, and then after around 4 weeks, we'll reassess him with his blood parameters, and we'll also go for a staging workup and then plan for surgeries.
What
In
staging
his
workup
case,
would you like to do in a
yes,
periampullary carcinoma?
yes. In his case, since he already has a contrast enhanced MRI, which does not show any significant lymphadenopathy or hepatic metastasis, at this point of time, he need not have. We need not go for any further staging other than ruling out chest, sir, with contrast enhanced CT or even at least a chest X-ray.
No, you have to do a contrast enhanced high resolution CT of the chest.
CT.
That is
Yes.
mandatory.
Okay,
Will
sir.
you do a PET scan? What is the role of PET scan in periampullary carcinoma
So periampullary
versus
carcinoma.
carcinoma head of the pancreas?
So routinely, it may not be advisable, but however, some groups do routinely do PET scan. In case of the feature suggestive of locally advanced disease with lymph nodal metastasis or suspicious liver lesion, we can go for a PET CT.
Yeah. Also in carcinoma head of the pancreas, the yield is better. So you have to do a PET CT in carcinoma head of the pancreas. Periampullary,
Yes,
not everybody would do a PET CT, especially if it is not shown any evidence of lymph nodes or liver metastasis.
yes.
Yeah. Okay. So what would you do? How would you go? What would your procedure be? How would you prepare this patient for surgery?
So since he is nutritionally well, we'll just go for the other parameters, blood investigations, uh, then fitness for surgery.
What
Then
is
we
prehabilitation? Is prehabilitation indicated in all patients with carcinoma of the pancreas?
rehabilitation with nutritional improvement, spirometry, and in a patient with long-standing disease, yes, sir. It's
Rehabilitation refers to nutritional comorbidities and
control. Yes,
cardiorespiratory optimization of the patient. So
yes, sir.
you have to do all three to be able to do a proper prehabilitation.
Yes, sir.
So you have time. You are waiting anyway for 1 week, 10 days. Use that
Yes,
for
sir.
prehabilitation. You will
Yes.
improve the patient's nutrition, you will reduce morbidity, you will reduce inflammation. So the results will be better if you do
Better.
it. So prehabilitation, always remember you have to do it if you have.
Yes, sir. Hello, sir. Hello.
Spirometry, and then you make sure that he is optimized.
Yes, sir.
Okay, let us assume you want to do a laparoscopic pancreatic or duodenectomy.
Yes, sir.
So, what are your port positions and how will you position the patient? How will you proceed?
Laparoscopic port positions are infraumbilical camera port, then uh, epigastric port, right lateral port, sir,
Mhm.
then left parumbilical port,
Okay,
and then some may use another port for retraction, sir, method retractor.
liver retractor also you will put.
Yes.
Okay,
Yes, sir.
first step is what? In laparoscopic Whipples, how is it different from open Whipples?
So taking down of hepatic flexure and retraction of the
That
liver.
is the step you will do in both. You
So,
prefer to isolate the third part of the duodenum and try to dissect out the third part of the duodenum
that-
and do a mobilization of the C loop of the duodenum and do a
yes.
cauterization. You prefer
Okay.
not to take down the colon because it keeps coming in the way.
Yes, sir.
So you prefer to do a cauterization. You prefer to do a mesocolic approach to the vein. You try
Yes,
to
sir.
dissect the vein and make sure that your artery first approach is showing a resectable lesion.
Yes, sir.
Before that, you will also sample the aorta cable node. You will send the
Yes,
aorta
sir.
cable node for sampling.
Frozen, sir.
You will do a frozen section. If that is
Yes, sir.
negative, you will proceed with the procedure. The rest of the procedure is sort of standard.
Yes, sir.
You bring down the hepatic flexure. You have mobilized the pancreas. You dissect the porta. After dissecting the porta, you put a clamp on the bile duct. You divide the bile duct. You get the bile duct down, isolate the pancreas portal vein,
Yes, sir.
connect the retropancreatic tunnel with the superior
Okay.
suprapancreatic portal vein, and
Yes, sir.
then you divide the pancreatic neck
Transaction
with
process.
the energy device. You then
Awesome.
ligate the inferior pancreatic duodenal vessels and
Yes, sir.
then proceed ahead. Some people tend to ligate the inferior pancreatic duodenal vessels initially itself so that they
Yes,
reduce
sir.
the blood loss during pancreatic transection.
Yes, sir.
And then you will proceed with the dissection of the uncinate process. You will remove the uncinate process and mesentery
Yes,
by
sir.
isolating the artery, and by using energy devices and by using clips, you will separate the uncinate process.
Answer.
You will remove the specimen and then you will do reconstruction.
Take it.
Reconstruction is done standard way. You do Blumgart technique or you can do just
Pancreatic.
direct anastomosis. It is
Yes,
duct
sir.
mucosa anastomosis, which should be done, which is
Yes, sir.
preferred. You may stent it or not stent it. Most people don't stent it, but
Yes, sir.
temporarily while doing the suturing, you can place a stent and then remove it later.
Yes.
And you ensure
Pancreatic.
hemostasis and good control, and you
Yes.
close the abdomen without drain in
No.
periampullary carcinoma.
Correct.
The logic being that if it leaks, you will get collections, and the collections can be done by interventional techniques,
Radiology.
and
Case reports.
morbidity is less because you have not put a drain.
Train.
Okay? Yeah.
Yes, sir.
So that is that. What are the complications of pancreatic duodenectomy?
Sir, early complications and late complications, sir. Intraoperatively or immediate post-op, there can be bleeding from gastroduodenal artery.
Mhm.
Then delayed gastric emptying is one of the commonest complication in
That
post-PD
is if you
patients.
do a pylorus preserving.
Pylorus,
So let
yes,
us
sir.
come to pylorus preserving. In the presence of
Yes.
a periampullary carcinoma, would you do a pylorus preserving pancreatidodenectomy?
So up to T2, where it is not more less than 2 centimeter, pylorus preserving can still be done. But other than that, if we are
Pylorus preserving
suspecting
neighbor now, can you do the duodenal cuff? Do you prefer
duodenal,
to take a duodenal cuff in a periampullary carcinoma?
sir, duodenal cup in a periampullary
Periampullary
carcinoma.
carcinoma, do
Yes,
you prefer to take it? Generally, they say because periampullary carcinoma involves the second part of the duodenum,
yes,
sometimes
sir.
the margin is not well achieved for the duodenum. So they prefer
Yes,
not to do a duodenum preserving. Conservative pylorus resecting
resecting.
pancreaticoduodenectomy has been done. That also obviates the 2% risk of suprapancreatic, suprapyloric and intrapyloric lymph node
Lymph.
involvement. So they do that. What are the different types of stomach preservation and what is the results of that? One is classical Whipples,
Whipples.
where you remove up to the middle of the stomach.
Yes, sir. Distal stone. Then
The
pylorus
other is
preserving.
pylorus preserving
Preserving.
resection.
Yes.
The other is antral preserving resection.
Focus.
Results are equivalent. In classical Whipples, initial post-operative weight loss is more significant as compared to pylorus preserving. But at
Yes.
1 to 1.5 years duration, there is no difference between classical Whipples and pylorus preserving Whipples
Preserve.
in terms of weight loss or quality of life.
Yes.
That you have to understand. Second thing you
Yes.
have to understand is that if you do a duodenum preserving pancreaticoduodenectomy,
Yes. Sir.
the chance of delayed gastric emptying is there up to 30%. Now, with understanding that you should not put traction on the pylorus so that the nerves of lateral jet get stretched, with that realization and gentle handling, the incidence has come down to 15 to 20%. It's not 30% anymore, and results are good. What are the contraindications for duodenum preserving pancreaticoduodenectomy? Pylorus preserving pancreaticoduodenectomy. What are the contraindications on the table?
So contraindications would include carcinoma, head of pancreas involving large mass involving the duodenum and D1 or even the pylorus.
Okay, what else? Technical
Uh,
factors.
Technical factors, sir.
If the duodenum becomes blue or congested,
Okay. After
then again
vascular ligation.
you have
Yes.
to resect the pylorus and do it.
Yes.